So we have a question from Deborah, which is, has integrated care improved the health outcomes of those that are marginalized or homeless? And a second question in relation to, have we made any progress in making palliative care available to those marginalized or homeless?
Thank you. So I invite anyone on the panel now to respond to this question.
Yeah, no, that's a great question. And obviously, in many ways, the proof of the pudding to all this energy we put into integrated care. And the research evidence on integrated care is very complex, as you can imagine, with a high degree of local context influencing what outcomes that are achieved. But there's two things I would say. So in terms of kind of vulnerable groups, in particular those with more complex needs, such as homeless people, etc., we can clearly see improvements in health outcomes, people's experience of accessing care if it's better joined up and coordinated. Issues such as, do people access hospitals less, is always tricky because there's so many other factors that influence it. But I think on the whole, we can generally see some positive impacts from better integrated care. And we also must remember that if we don't integrate care, what we have is fragmented care. And there's numerous research studies which highlight that if we don't join up, we don't communicate, we don't coordinate, we don't put people at the centre, what they receive is poor care, and care that will not be focused on their needs and perhaps indeed may overlook those needs. So I think we can definitely say that integrated care is able to make a real difference to those vulnerable populations if it's well planned and it has people at the heart of them.
In our work, what we also found is by increasing that awareness and connection at that community level, then those are the folks who actually know those marginalized populations. And so then that you have to get really creative about how those voices come to the table, but it is possible to do. And it is really through building those relationships. And then you start to adapt things. And one of the things that we found really was that those folks who were marginalized and homeless was one of the ones that came up in our work. Really, it's around where they are. They have a community where they are. So sometimes our solutions pull them away from the supports that they have. And so we need to look at how do we do things right where they are with the people that are around them.
Yes, please, Sandra, please go ahead.
Yeah, it's ironic. In my spare time, I volunteer for Gravenhurst Against Poverty, and I attended our Alliance Council meeting. And so it's a community coming together. And it was really interesting to hear people from Canadian Mental Health, the OPP, the Public Health Unit, Salvation Army, Canadian Blood Services. And so, we talk a lot about the effects of social determinants of health. And so one of the things that, I've addressed with the PFACT, the minister's PFACT, is how can we get our healthcare systems also working with our public health systems? And how can we share that information? Because like here in Gravenhurst, we have our family health team, and then at the back, they have the district community public health service, but it's referred to as a welfare office. Well, it does so much. There's no such thing as welfare as Ontario Works, but there's so many resources that are there. So if we can get those two sectors working together, and this is the whole point of collaboration.
Thank you, Sandra, and really great example. And I want to highlight as well, and it's come up a couple of times, Helen, how you talk about when you can reach out into the community, they could reach further and find individuals, who we want to connect with. And Sandra, in your experience, you're seeing like what organizations are critical in terms of what needs to come together for people. Because often we talk about we need to diversify the people we work with, but one relationship then builds into another relationship, which builds into another relationship. And I really wanted to highlight that because personally, that has helped me in my engagement work as well with my teams. So I'm going to bring it back to you folks, all the participants today. And Yinka, any other burning questions that are coming up in the chat? I see it's brimming with comments and resources and questions. So let's go to the next one that you see.
Lots of great questions and comments. A question from Liz Denier, wondering how we effectively move the bar through the stages of engagement you mentioned. How do we get from level 2 to level 3 to really equally integrate patients into the process and continue to break down the power differential?
Such a great question. So you'll recall the slides, how we had different degrees of power sharing and different degrees of engagement. we're talking about moving to that third really evolved phase of engagement. Does anyone want to take that on? How do we get there? So it's not a one-off, but more of an ongoing form of engagement.
I'll start the conversation, Carrie. So first of all, we need for health, those who are wanting to start to co-sign, to realize what lived experience is an asset. And as I said, it's where the magic happens. And I think, when Helen said, they thought maybe 1 or 2 projects, but once you start inviting the families, patients and caregivers and community, the conversation starts and you see how it works. And I see this a lot in research, but you have to try it. And until you try it, you don't know it. But it has to start at our government levels as an expectation and at our leadership. And, Carrie in Ontario has done some excellent training on it, but it's something, it's something that you have to learn. But also I wanted to appreciate, though, that, engagement and partnership is over and above everything else of what people are doing. But once you do it, I think it's going to reduce the amount of workload that is being put on our healthcare providers and our sectors.
Thank you, Sandra. Go ahead, Robin. Yeah.
Oh, well, I was going to bring in Helen, but that's fine. So, thanks, Sandra. That's very, very, very helpful. And Anne Wojtak and I at University of Toronto just finished a project looking at co-production integrated care. I mean, we talked to 25 people in 12 different countries who've been seen to make an influence. And one thing was quite surprising was some of the basics of co-production that we don't often do. Those issues about communicating with people, making sure we put venues that are accessible, that we make sure we correspond in a timely way, that we treat people with respect, that we have continuity of individuals working with them. Some of those practicalities, which we know make a difference, but we don't necessarily embed in what we do, are so crucial. And there is something about being involved with the long term. I think there's a terrible history in integrated care. We start off doing a new program, and so we think, yes, we must communicate with the community, we go out and speak to people. And then as we get in the busyness and challenge of implementation, we then get distracted from that. And we let people drift away and we don't involve them. And that both removes the opportunity for them to shape and improve the program, but it also makes people very cynical and skeptical about how honest and how authentic that engagement was. So there's a real need to cover the practicalities and to engage with people in the long term, because when we get to know people over a longer time period, we get to trust each other, we get to respect each other, we can say difficult things, which is what we need to get to in co-production, because we're not always going to see the world in the same way, but that only happens if we do it over a long-term period so we can develop that trust.
Just wanted to build on what you were saying there, Robin, and talk about that. I think that there's a specific role for helping shepherd that along. In our project, it's us as what we call our provincial team, but there has to be support there for the individuals as well as for the teams who are working on this, and then information to go up to our decision makers. So there's an in-between role there that I think is not always present in some of the work that we see, and then it creates that some lack of continuity in information sharing.
Sorry, just to add on a little bit more to what's already been said. I definitely agree, Sandra, Robin, Helen. Lived experience is an expertise, and it should be treated as such, and it should be compensated fairly. So what can happen oftentimes is, again, folks will come into different community spaces and say, we'd love to hear from you, we'd love to hear your feedback, and then they don't get compensated for their time. So whether it be financial contributions, whether it be, childcare, et cetera, just like Robin said, there are so many little tiny details that oftentimes get lost in translation when we're trying to actively engage communities, caregivers and patients, that those little things are the things that folks will remember. And then they'll take that up and say, I might not actually want to actively participate in the next round of conversations. And I, myself, Carrie, Walter, we also work from the learning health systems perspective, where, the idea is that the research informs practice and practice informs research. And in, the conversations that we've had recently about the learning health systems is really centering the patient, caregiver, and community as the key cornerstone and
part that moves the conversation around advancing health systems and care as alongside equity. So if we don't have those two core components in the health system and systems, we can't actually move things along. So if we don't make sure that those portions of the system are working, and we're not actively engaging and making sure that we're linking folks to the care that they need, and also making sure that we're having conversations that are consistent so folks see the continuity and see our interest and see their feedback and perspective taken up and actually used to inform practice and care, then the whole system goes to hell in a handbasket. Pardon my French, but yes.
Thank you, Nikki. I always look for sound bites. I like that one. Speaking of sound bites, Sandra, I just have to quickly highlight something you said. You said lived experience is an asset, and it's where the magic happens. And I just said, yes, as soon as I was thinking, that's exactly why, we need to value the knowledge and expertise of patients, families, and communities. It's such an essential piece of what we do. And Robin and Helen and Nikia, thank you for reminding us of the fundamentals: accessibility, showing value in different ways, and really being thoughtful about how we're creating to connect with individuals. So those are a few things that stood out from that response. I'm going to flip it now back to the chat, because I know there's lots more questions coming in. So Yinka, anything that you wanted to pull out of that to keep our conversation moving?
Definitely. Great segue. We have a question from Laura Collins. How do you prove that investment in patient voice and engagement is worthwhile? How do you convince senior leaders that in times of austerity, this spend is crucial?
I think it's really important that we show impact in lots of different ways. I think the stories from the people who are involved, and then the stories from the people who are impacted, are key ways of being able to say, within the communities we worked with, there were no supports when we started this work, and now there are supports. So that's a dramatic change. But we also looked at things like the impact of the healthcare system, but also a social return on investment to show the impact to all of the publicly funded systems, which equaled the impact to people living with dementia and care. So we feel like that's a huge win for that. But then there's things around, counting some of the numbers, because people do like to hear numbers, as well as, doing formal evaluations. So I think we have to look at lots of different ways to bring that information together.
So what I was going to say, it's important to measure impact, right? So I'm working on a project and a research on using the performance measurement engagement tool that came out of the Center for Excellent Patient Partner, CEPPP. It's out of Quebec. And, because we have to measure, and it's difficult to measure. And as I said, until you do it. But so, when we start looking at, we look at performance measurements, and we look at, time people wait to, see an ER, time people get a doctor. But we also need to measure how our organizations are doing in patient engagement. What involvement does the community have? What voices does the patient have, and stuff like that? And we also have to remember too, unfortunately, our healthcare system was not built for the end users, right? And it's not until you step out of the system and you start looking at it as a whole that you realize that.
Thank you for your response. Did anyone else want to add on to Sandra?
Sure. I just wanted to quickly add on to Sandra. Oftentimes we measure performance and whether, healthcare is doing well by numbers. However, coming from a qualitative mixed method approach in my world, I often say that numbers without context are just a bunch of numbers, right? And if we're going back to, the big wigs of various institutions, folks like stories. They like to have some kind of context put into the numbers. So if you say 55% of healthcare users had great outcomes, that's wonderful, depending on where you are. Again, just a general example. However, you say 55% of users had great outcomes, and here's a story about so-and-so who came from such and such and whatnot. And if we highlight that story, if we provide context, if we talk a bit about the social determinants of health and how, a particular program or organization helped that individual to get a better health outcome, then oftentimes what'll happen is that quote unquote big wig will say, oh, okay, well, that's interesting. I didn't realize that those numbers actually were, there was a person behind those numbers, and these are the positive outcomes, and this is the impact that had not on that person, not just on that person, but oftentimes, you know, when folks are coming from various communities, racialized, you know, underrepresented groups and whatnot, they're taking the learnings that they've gained from their engagement in various healthcare systems, and they're sharing that with their loved ones. They're sharing that with their peers. So you're not just helping that individual, you're also providing, you know, opportunities for learning and potential additional engagement from folks who may not have access to a particular system or, you know, program because of a number of issues that they may have experienced in the past trying to access those various services. So definitely, you know, again, like I said, data without context are just a bunch of numbers, but from that context, you also have an opportunity to impact other people in a way that you may not have anticipated.
Thanks. Just to add to what Naki said, what was excellent, and the others too. I mean, I think it's demoralizing, isn't it, a little bit, that we still have to convince people that involving individuals and families in their own care is a fundamental part of a quality health and social care system. But and I do think also, I mean, I know generally with integrated care, we're for kind of locally developed solutions that emerge from good practice, but I do think sometimes there's a role for government to actually just say this is not good enough. And, you know, it should be part of your regulatory system that you look at whether or not people in communities are involved in designing and delivery of health and social care systems. But beyond that, if we do have to convince the senior decision makers, one thing we need to be aware of is what's important to them. You know, what is it on their desk that's actually giving them sleepless nights? And often that's to do with over demand on particular services and worries about budgets running out of control, etc. And if we can demonstrate that involving people and families in those services and those pinch points will make a real difference. And one of the things we looked at in the Mid East Antrim project was we noticed that often when people thought about social prescribing and involving community activities, they thought about people with kind of low level need who had kind of longer term isolation issues, which are all very important, but they never really thought about acute crisis issues. And one of the things that they really struggle with in Northern Ireland is enabling people to leave hospital in a timely manner. And that then leads to people spending longer than they have to in acute care settings, but it also means that other people can't be admitted. So one of the things we looked at in the project was, well, could social prescribing have a role in terms of enabling older people to leave hospital in a timely manner? And whilst it was only a 12-month project, the emerging evidence we had was definitely, because actually lots of the issues that prevent people going home and staying at home are to do with social networks and isolation, and some of those practicalities of having food in the house and having some of those basic repairs done. So then the point is to look at what are the pressure points for those decision makers and evidence how involving people will help them with those pressures that they have on their day-to-day work.
Yeah, I just wanted to add to it a thought that came to my mind also that we found in our work is that it really impacts workforce. And I think this is a global issue also, right? That people, there's getting to be fewer numbers. But what we found with these community teams is that they loved the creativity that they had, that they were actually able to see things be created and be rolled out within their communities. And so I think great satisfaction for that workforce part of it to keep, you know, that retention kind of area with it. So I think that's another selling feature for our leaders.
Thank you for that. And I think about this concept of like windows of opportunity and sometimes strategic framing in terms of what we want to get done, you know, with our communities and for our communities, but looking at that broader climate, which, you know, and the context of the organizations that we might be situated in with very clear directions or pressures or imperatives, and how to kind of find that sweet spot where we can come together. And so that's what I'm taking from this dialogue. And I think it's strategy and engaging communities for integrated care is critical, just so we're not kind of spinning our wheels and engaging and then things aren't going anywhere. Where's the receptor in the system that we could link it to see that change? And so that really sparked excitement for me in hearing that dialogue. Does anyone else want to add, or should we flip it back to the Sandra, and then we'll go back to the audience?
Yeah, quickly, because I originally wrote this down. So, you know, when you look at integrated care, and let's look at like a family health team, or in the bigger cities, they'll have like a primary care network or community health hub. You know, there's a lot of pressure on our primary care doctors, and there's a lot of administrative burden on there. And I don't blame them. Like, you know, like we were looking at something about the amount of time. It was on LinkedIn. People were saying like how much a doctor got based on their clients, but you know, there was run like a business, a lot of them, about like their staff and everything. But you know, there's also this things that we refer to as PJ time, when the notes are done, you know, and I have specialists and I get emails like, you know, midnight and 2 o'clock in the morning, you know, 5 o'clock in the morning. So to me, it's like, as a patient, I visualize an integrated care place where I can walk in, and as a patient, I can choose before I get there how I want to receive care. Do I want to go in? Do I want to get a virtual appointment? But I also want to be able to go in and say, well, do I need to see the doctor today? Or could I see a nurse? Could I see the social worker? Can I just go see the OT? And like, you know, unfortunately, the way our systems are built here, like at Ontario, and I can't speak for across Canada or internationally, but the doctors are sort of almost like a gatekeeper. They have to see every single patient just for them to see like a social worker or something like that. So to me, that would be the best way to get integrated care, where there's a one-stop. And that would also include, that's what I said in my opening statement, where it's physical, mental, and social, and that you can get it. And as I was talking to the people this morning, I said, you know, you should have information available when I'm going to see my primary care doctor, that I know that there's other resources there. But I also think that, because unfortunately, I heard a stat that only 85% of Canadians are receiving healthcare, and that's not right. So the other thing is, what I really strongly believe about community is we have to go where the people are. So does that mean that we go to the person that was talking about the Alzheimer's? I think that was you, Helen. You know, my mom goes to the Alzheimer's Day program. Why can't a primary care doctor go there and see 20 patients at the same time? Go to have a health hub at the university, you know, go where people are. So
thank you, Sandra. And your example reminds us that the answers, you know, sit with patients, caregivers, and communities in terms of how we could think about systems and how we set them up in a very different way. And you also identified what brings you most value. What do you need? What type of provider would be most helpful based on the needs you have, the concerns you have? So there's an element of choice, is what I heard and what you were talking about. So thank you for sharing that, because it brings us back to, why are we doing this, and why is the engagement so powerful with patients, families, and communities? Is because they're the ones using the entire fragmented system.